Okay, I'm really happy to introduce Dr. Sargunadevi, Sivanantham, who's a senior clinical embryologist, and she's Health and Care Profession Council UK registered. 19 years of clinical experience she has. She holds current position as Director of Embryology Academics in Arvind IVF and past employment ARC, Kraft, Women's Center, Manipal, Ankur, Prashant Hospital, and all. And I don't have to have introduced Sargunadevi, so I'm waiting to listen to your talk on frozen assets.
Okay, so very good afternoon to everyone, and thank you for the warm introduction. And thanks FOGCE, Mr. Rajesh and Dr. Aruna Ashok to have me here today for the presentation. The topic of my presentation today is about frozen assets, the precious oocytes and embryos, and how we improve the cryosurvival rates and the further outcomes from the cryopreservation of these specimens. So cryopreservation is nothing but preserving any living cell at ultra low temperatures at a genetically and physiologically stabilized state. So as we all know, cryopreservation of oocytes and embryos play an integral part of ART programs. The scenarios for cryopreservation are many, and it made our lives better and easy. So when there are surplus embryos after fresh embryo transfer, or if a freeze-all strategy is applied for future frozen embryo transfers, if the patient is scheduled for a BGT or a poor responders coming in, and then the plan is about cryopooling of oocytes and embryos, fertility preservation, social egg freezing in whichever countries it applies, and donor cryobanking, as well as the days where we have some surprises in the laboratory, the husband will not be able to give a sample and there is no backup, we may have to freeze the oocytes. So it is helpful in various ways so that we can plan things better and there is no much loss for the patients. Two different methods of cryopreservation were popular. First one is a slow freezing, other one is vitrification. Slow freezing, I have introduced a picture because most of you might not have seen this equipment at all, and it includes big machines. That's what you see, and they play for 1 to 2 hours depending on which sample we freeze in the lab, and some of us might have been experiencing with this. So the liquid nitrogen tank will pump liquid nitrogen into the bigger equipment to bring down the temperatures in a programmed manner so that there is a cryopreservation happening in an efficient method. And vitrification, now currently in practice and most popular one, has taken that away, the space away, and it is very quite simple, easy to do, and we are all doing it as an ultra rapid cryopreservation of the clinical gametes and embryos. So quite often, ice crystal formation is the term we use, which is causing the cryo injury to the tissues frozen in the IVF laboratory. So to explain that, any long-term or short-term preservation of tissues which requires cessation of biochemical reactions at ultra-low temperatures will cause ice crystal formation from the water molecules present in the tissues. So what exactly happens in sub-zero temperatures? Automatically the water is frozen to ice crystals. But what happens extra is within the cell, the solute concentration is going into unimaginably higher rates because water is out. So that is what is going to, it's lethal and it causes cell death. That's how we lose the tissues during cryopreservation procedures. And one more theory about ice crystals affecting the cellular membrane, they disrupt the cellular membranes and making it impossible to recover the structurally intact cell, post-thawing. So the avoidance of ice crystal formation is the key to a successful vitrification. This is what we need to remember first. And here comes vitrification. So it bypasses the ice crystal formation more or less. And it's a method of cryopreservation where the reproductive cells, your oocytes and embryos, are converted to amorphous glass-like solid at lower temperatures without any ice crystal formation or with minor formation of ice crystals. So in scientific reports over the past decade have proven the improved viability of the embryos frozen from vitrification, showed improved efficiency and safety in the ART procedures involved. So talking about the principles, I thought it's very important to know about what's happening exactly in vitrification, how it makes cells into amorphous glass-like structure. It's like vitrification, it involves two different mechanisms to have a better survival of the tissues. One is rapid cooling and warming rates. Other one is addition of cryoprotective agents. So the process of vitrification happens when the substances pass threshold value and the bonding between the molecules becomes really high. So rapid cooling and warming will take care of substances passing the threshold value, and the cryoprotectant, the mixture of vitrification solutions, to enhance the chemical reaction, that is the bonding between the molecules. So two ways it is helping that to happen, so that there is no a loss with the ice crystals. Just to explain, is it working? I don't know. So the crystalline structure, if for example it's an ice crystal, you can see a regular arrangement of the molecule. This is how they look. But when it is going to a glass-like vitreous structure, it is amorphous. It's an irregular arrangement which is on the right side. So for a successful vitrification, your cells have to be converted without irregularity to an amorphous state. The size of the cells should remain the same, so they are becoming viable in the future when you thaw them. And if it doesn't happen, when they are arranged in a regular base, it is going to be a failed vitrification cycle. So all we need to know about the solutions is permeating as well as non-permeating cryoprotectants are used in the vitrification processes. And about the PAs, that's permeating agents, they are small in size. They can move across the cellular membranes. And what they do extra is they bind with the water through hydrogen bonding. On the right side, I have DMSO and ethylene glycol. That's the most popular permeating agents used in the vitrification solutions, just to have an imagination of a chemical structure. So how they work? They combine with the water molecules with hydrogen bonding, so that the freezing point of water is depressed, as well as loose water molecules are not present to form ice crystals. This is how it works. Okay? And the permeating agents also affect the membrane dynamics, and they increase the cellular permeability, so that there is an efficient movement of the molecules between the cell and the extracellular area. Coming to the second one, non-permeating agents. Like you might have heard, sucrose and trehalose are the most popular ones used in the vitrification solutions. They are relatively larger compared to the permeating agents, so that they exert their protective influence outside the cell. Thank you. So these non-permeating agents, they also induce vitrification in the substances with the same mechanism as PAs, but to a lesser extent. They will stay outside also, it's extracellular. And they reduce the PA-induced toxicity for the cell, so that the cellular viability is also increased. So this is how vitrification gives a better survival of the tissues for us. So during the vitrification procedure, so each one of you might be using a different brand of vitrification media. They might be giving you different solutions for that stage specific, or the temperatures, like at 37 or at the room temperature where the steps are going to be carried out, or they give you different cryo devices, whatever it is. They involve two different solutions, that is equilibration solution as well as the vitrification solution. So when you're moving your reproductive cells, that's the oocytes or embryos, to the ES, what exactly happens is immediate adjustments of the osmolarity between the solutions. So the CPAs, that PAs, that's protective agents, they will penetrate into the cell. At the same time, dehydration happens, means water molecules exit and these solutions will get in. So further dehydration happens in the VS solution, so that it becomes more with the chemicals inside, and then when you are plunging this cryotop, cryolock, whatever device you have into the liquinization directly, that is turned to a glass-like structure automatically, because there is no time for these ones, even the water molecules, to arrange themselves into an ice crystal at that time, because you are very quick. You're going straight onto the liquinization. So this is the process of vitrification. Higher cooling rates, this is about 43,000, maximum 43,000 degrees Celsius per minute is achieved when you're going really quick into the liquinization. More than that, highest warming rates are important to have a better survival of the embryos. So I have had quite a few interesting questions from the organizing team to talk about during my presentation. This is about troubleshooting. So first one is single cell degeneration at cleavage stage vitrification. So for example, if you're freezing an 8 cell, 7 may be surviving, 1 cell may not be surviving at the time you thaw them, and you wonder why. And so there could be two different reasons behind this. First one is, it is from the quality of the blastomeres themselves, the quality of the blastomere from the embryo. Second one is the vitrification process itself. So when it is one or a couple of cells, you might think it's certainly the blastomere quality. And if it is more than half of the blastomeres degenerate, then there is an insufficient dehydration during the vitrification process. This information has been given directly by the quality control department of one of the most popular brands of vitrification solutions we use when I had a personal interaction. So how would you manage it? So slightly, if you're seeing it frequently that you're having one cell or more cells dying, that you may have to expose the cleavage stage embryos slightly longer to ES and VS. That is what the suggestions they might be giving. Next comes oocyte vitrification. So you may be freezing oocytes, cleavage stage embryos, as well as blastocysts. The blastocyst vitrification and thawing, we see most of the time they survive very well, close to 99% to 100%. We are happy. But about cleavage stage, I have explained. When it comes to oocyte vitrification, it is still a challenging thing to achieve 100% survival for some of them, or most of the times we don't know. Sometimes it's 100%, sometimes it's 80%. Rarely you might lose all the oocytes also, though you followed the manufacturer's instructions very clearly during your oocyte freezing protocol. So why this is happening? Because their vulnerability from the three main factors are to be considered here. They are large in size. Okay, they are one of the largest cells in the body, and they have high water content within them, and they have fragile cytoskeleton structures. So any vitrification media and the process, what you do, it has to consider special structure and the sensitivity of the single large cells, these oocytes, and the overall physiology. As well as it has to evaluate the time and the exposure to the CPAs. What is the concentration and what is the duration of the exposure to the CPAs has to be considered, as well as the maturation interval, pre-freezing and post-swarming has also to be playing in place, as well as to introduce the CPAs in a gradual manner rather than just giving them a particular shock on an immediate exposure, to minimize the potential cytotoxicity from the CPAs and to optimize the viability to give a developmental competence to develop to a good embryo. So during freezing of the oocytes, a completion of dehydration is very, very important, and it is characterized by the oocytes changing their shapes from normal to a bowl or raisin shape, and you see them not floating anymore on the surface, and they settle at the bottom of the droplet and the dish. And the distortion, so the media surrounding the oocytes, you are not seeing it anymore, then you may know it's a complete dehydration. And keeping the oocytes to a maximum up to 4 is easier because they're very translucent when you thaw them, and keeping them towards the tip of the carrier device is also very, very important. So it becomes easy at the time of thaw. You're not looking for eggs in the first 1 minute. Also, while thawing, if you're not seeing the membranes in a distinct manner, then you may have to leave them slightly longer than 1 minute. That is allowed actually by one of the manufacturers, I would say. And bring the previous solutions. So TS, carry some TS with the oocytes, take it to the next DS and WS, whatever. So just carry some solution so that there is a balanced dilution. And this I apply for all the embryos and oocytes as well. And so more than that, you have to consider the patient's age, the history, and the quality of the oocytes from the stimulation protocols. We have multiple anomalies nowadays in the oocytes, and you may have to think about what survival you would expect from the stimulation and the patient's age and what physiology. So general tips for successful vitrification. Probably you have to follow the manufacturer's instructions, follow the desired temperatures and duration during the procedure. There may be small deviations because we are all doing it. We may be going early, but it's, as long as it gives a good survival and a better outcome, it's not a problem. Use stripper at least 10 to 20 microliters larger than the specimen so that they are not crushed. And exposure to ES as you wish. You see it's regaining the shape, it's more than enough. That's what I always think, because the future is ultra rapid vitrification, because it's going to be like minimal amount of minutes. That's what we are expecting in the future for freezing and thawing. They've been working and there are publications coming out, so we may be using less. So, and then the volume of the vitrification solution. To have a normal volume of vitrification, don't remove too much, don't add too much. About the cryo devices, there are closed and open system. You may be using different ones, particularly loops and the flat ones and the capillary light of like straws. So in the loop, you have VS loaded with the embryos. In the flat ones, as you all may be popularly doing, they're loaded at the tip of the device, and in the capillary, you may have to leave it close to the embryos towards the end of the VS exposure, so that by the capillary action, they will get into the straw and it's closed. So optimization of cryo storage, that's quite it's a vast area, I would say. So the location and accessibility to the cryo tanks is important. The number of tanks required as per the load, the preparation of the tanks before you use, and maintenance of the new storage tanks are very, very important. Proper labeling of the tanks and double witnessing at every time when you do the lab procedures in the the SOPs to be developed for freezing, storage, as well as quality control, and there should be some adherence. There should be an internal check that is being adhered regularly on everyday basis, and if possible continuous monitoring or regular monitoring of levels of supply of liquid nitrogen to the divas are important. So if possible, you may have to have an oxygen monitoring system, alarm systems. I don't know how many of us are having now, to think about the safety of the personnel working here. Preferably a locking system, because you need to think about the safety again. And it is an international recommendation to have locking system. It's just not like what we think here. So infected samples should be kept in separate tanks. So all requires a skilled personnel to make a design of everything and appropriate protocols for operation, as well as clinics should have policies for retention time and when to dispose the dormant samples, like how it was beautifully discussed by other speaker. So record maintenance, again it was almost covered. Consent forms for cryopreservation are about transfer to another clinic to be well maintained. Lab records, any lab event to be mentioned. So just if it is a cryopreservation record, that should carry every information, the date of freeze, day of the embryo development, the grades, who has done it, who witnessed it, who stored it, the color of the cryopreservation devices, etc. Everything should be there. Double witnessing at every step, and the signatures with the time, as Madam has mentioned, is something very, very important. Keep entering your data so that there is enough data available for you to just retrospectively look at your outcomes from your clinic. And the data entry, if you have a suitable software, if you are lucky, it's well and good. Otherwise, at least you have to maintain an Excel spreadsheet. So checklists for routine liquid nitrogen checks, as well as the maintenance of the levels. And you should maintain a non-conformity register. You have to enter all the incidents, because that only is going to give you the root cause analysis of the problem, and you have to find a solution so that it doesn't get repeated and you don't have much of loss in the laboratory. So staff training records for all these ones, like for the procedures, how to maintain, and the optimization of the cryo storage areas, etc. Plus safe liquid nitrogen handling must be carried out, and it will be helping. So this is the end of my presentation. So the future of cryopreservation is like we have to accept there is an undeniable growth in the cryo inventory. We freeze a lot of oocytes and embryos because we are going ahead with the improved outcome of when in terms of embryo numbers in the laboratory. We are freezing more, we have single embryo transfers. For different reasons, we are going with more and more. And this is something very, very important, that we should not have any misplacement, we should not have any loss. We are not spending time on it. So recently RFID, radio frequency identification system is in place. And if we get something for lesser cost, it would be better for us in the future. Go straight onto the tissue and then get it, rather than spending time on it. And automated platforms are expected to be available for us in the future for an improved safety, identification, and management. And improved cryo tank designs, so that we are not having any broken lids, and etc. And early alert monitoring systems will be available in the future. And I'm expecting low concentration PA vitrification system, because we are talking about the toxicity of the applied cryoprotective agents. So that may be available for us to make things easy. And there was a interesting paper about micro-encapsulation of the follicles, actually the antral follicles. So in future, I'm expecting these microgels can be applied to the tissues, the oocytes and the embryos, so that they cover that, and then they reduce the toxicity of the CPAs applied. And the warming can also happen in different fashion, like nano warming, by laser heating, etc. So this is all going on in animal studies are carried out on these matters, and I'm sure like we will get something like that in the future for human tissues also. So these are my references, and I thank you all for your patient listening.
Thank you, Dr. Devi.